My name is Dr. Nasir Khan. I'm working as Associate Professor of Psychiatry in Queen's University, Canada. Uh, I was working as Professor of Psychiatry in Pakistan, now working here. So we will continue with our topic of antipsychotics. Unfortunately, I don't know, somehow or the other, I was getting apprehensive that this topic is bigger, 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 and getting more bigger. So every time when I sit back, I realize that there is something missing. So let's put this slide as well. So things are getting more and more. But I hope we'll be able to cover most of it today. If not, definitely by next time. So, starting back again, when we say safety of the antipsychotic, so when you prescribe antipsychotic to people, of course, there are multiple other symptoms jahan pe you can prescribe these medications. Like people do prescribe them in dementia, people do prescribe them in old age, people do prescribe it in children, people do prescribe it in other disorders where aggression is a common feature presenting symptom. Now, do we realize that this indication of antipsychotic to people is okay or not? If we believe that the aggression should be treated with antipsychotics, we have to be careful about certain aspects. Like in old age, in behavioral and the psychological disturbances, the symptoms of dementia, usually it is said that the antipsychotics should not be prescribed. Even then, in majority of the prescription that we come across, people with dementia are prescribed with antipsychotics. Now, why antipsychotics should not be prescribed to people who are elderly or children? There are certain parameters for it. So the aggression can be controlled with other methodologies, and most important of them is that we should see the individual rather than the symptoms. Maybe he's getting irritable because of something. Maybe he is not able to express the pain from which he is suffering. Maybe he is able to have, maybe he is having some physical issues due to which he's having uncomfortable situation and getting aggressive. Or maybe the situation is too bad and we are not able to address the situation like in the family, in the relatives, the place where the patient is living, that is complicated. So just people coming in and talking to you about aggression never means that we should try to prescribe antipsychotics. Antipsychotics should be prescribed only to people where they are indicated. That is important to start with. Now, moving forward, there are a few other things. Like giving an example, this is a slide by Psychscene. Quetiapine have an effect on histaminergic, M1 and M3 receptors, alpha 2, D2, 5-HT2A, 5-HT1A, NRI, 5-HT2C. Now, when I'm showing these receptor sites, the idea is not to confuse you. The idea is when the antipsychotic is covering so many neurotransmitters, of course, they will have therapeutic benefits if the symptoms are associated with any of these receptor sites, and they will have side effects because of these receptor sites as well. So supposedly if the patient is not able to sleep and you give quetiapine to make sure that the person goes off to sleep. So maybe his sleep will improve because of these sedative actions on H1, but the sedative effect of H1 receptors can be achieved with antihistamine as well, like citrazine, which can affect on H1. But again, people will start gaining weight, they will have again aggression and uneasiness, or maybe some other side effects related to the other neurotransmitters. So the idea behind the fact is that if you prescribe antipsychotic in any population where it is not indicated, जिसको हम off-label indications बोलते हैं, if these off-label indications like sedation, like aggression, like agitation, like calming down effect, all these off-label indications of antipsychotics, we have to be very, very careful because with calming down effect, some other symptoms will come in as well, which could be devastating for the patient as well. So we should not treat the symptoms, we should treat the diagnosis. If the person is having psychosis, any form, now with ICD-11, I was just going through that, the psychosis is changed to different diagnostic categories. So जो labels हैं, they have been changed. Previously, schizophrenia was F20, now it is something else. We will talk about ICD-11 very soon, inshallah, with some presentation, and because your examiners are fond of ICD, I will definitely try to make sure that you know ICD-11 as well, very well, so that in exam situation you won't have any problems. And do expect some questions from ICD-11 in coming examinations. So we will try to cover that. So coming back, the off-label indications of antipsychotics are tricky and you have to be careful. Clozapine, very few EPS, no prolactin release, causes agranulocytosis, weight gain, seizures, and sedative effect. Now, people who are prone to develop seizures should not be given clozapine. But if they have tendency to develop the seizures, you can start the clozapine, but you have to give a coverage with anticonvulsant simultaneously to make sure that he won't develop a seizure. Similarly, risperidone has low atypical antipsychotic, very good drug otherwise, but EPS at high dose. Low propensity for tardive dyskinesia, but be careful, and less weight gain as well. But long-term use of risperidone may lead to certain complications. Olanzapine, again, no prolactin release. It is very highly sedative drug. यहाँ पे ये गलत लिखा हुआ है in the slide. It is a very sedative drug, and weight gain is the biggest problem. Ideal weight gain with 10 milligrams of olanzapine is 20 kilograms in 3 months. So if a person is 60 kilogram in the beginning of the treatment, they will be 80 kilograms in 3 months' time with olanzapine. This is a rough estimate. Of course, as you go up on the dosage, the weight gain goes up as well. So, डॉक्टर साहब इसको म्यूट कर दीजिए. Thank you. Okay, coming back. Same ziprasidone. Now, ziprasidone is a very good drug in a sense that it has low tendency to develop the EPS, no prolactin release. So people who are having the sexual side effects can be given ziprasidone. Weight gain is not an issue with this drug as well, but it's a weak drug with weak receptor occupancy on various sites. So it's not a very potent drug which can have good effect on dopamine and other receptors, and antipsychotic effect is compromised as well. So whenever you are prescribing an antipsychotic, this is another discussion. I will definitely try to cover that area as well, that all neurotransmitters involved give rise to different kind of symptomatology. So overall diagnosis may be schizophrenia, but the symptoms in it are usually associated with the neurotransmitters involved in that person. If you are able to correlate the symptoms with the neurotransmitters, you will find a good drug and the patient will be okay. If you won't be able to correlate the symptoms with the neurotransmitters, then whatever the drug hit and trial you will try, it may not have a good effect. So always remember to make sure that all this array of the neurotransmitter leads to some kind of symptoms, and those symptoms needs to be addressed with appropriate antipsychotic drugs having a good effect on these neurotransmitters. अब ये neurotransmitters आप सबको पता है, I won't go into that detail, but this is a complicated slide. Now, coming to another issue, people giving the Depo injections. Most important part is that whenever you give a Depo injection, don't expect the effect to come in right away. We think that as soon as the Depo injection is given, the patient will be sedated, his psychosis